So our final speaker in this session is Professor David Healy, who I'm sure you all know. He's a consultant psychiatrist and a professor in the University of Wales, and he's written extensively about various psychiatric drugs and has been particularly instrumental in drawing attention to the side effects of SSRIs.
Actually, the first thing that I want to do is to thank Millie for having convened this meeting and for having asked me to come and talk. I think this is the kind of meeting that should be happening in medicine, but isn't. It's awfully interesting that it takes a person who isn't actually a doctor to run a meeting like this. You have to wonder what medicines come to when we don't run meetings about what the problems might be of the treatments we give. And the ultimate theme that I'll end up with is just that point. What has medicine come to? In the meantime, just if you were in the same shoes as Claire or Millie, and you had a wife or a husband or a child who had been put on a drug and things had gone wrong on the drug, chances are if you'd gone to the FDA or if you'd gone to your kind of local doctor or prof of medicine or prof of whatever, you'd be faced with just the same response, which is, we're awfully sorry this has happened to you. This really sounds truly awful, but unfortunately what's happened to you is just a case report. It's an anecdote. The science looks the other way. We've put all the trials together and there isn't any signal from the trials that the drug could be causing the problem that you think has caused your wife or your husband or your child. That's what happened when people first reported Prozac causing problems. This led to hearings within the FDA when a string of people actually presented what had sort of the things that had actually gone wrong for them or their husbands or their wives or their children, and were they actually found themselves faced with the FDA saying, but actually the science points the opposite way. So, I should be using this. And here's the science. This is from the BMJ, 1991. 14 years before we get around to actually recognizing that this group of drugs could be causing problems. This is the science. These are all the clinical trials put out by the pharmaceutical company that made Prozac. And there's the data there. And the data gives rise to this. It shows that there is an increased risk on Prozac that you will go on to a suicidal act. It's an almost twofold risk. There's a close to twofold increase in the risk. That's just the same kind of risk that we find now. 14 years ago. It was this kind of data that was put in the weighing scales against the reports by people like Millie and Claire. And Millie and Claire's accounts were found wanting. Let's have a look at what the BMJ has to say about the data here. Let's have a look at what the company had to say about their own data and what the BMJ were happy to report. As you'll see there, it says that when we run the tests on the data that we usually run on data of this sort, that it reveals that there's no statistically significant increase in risk. Now, half of you in the hall, I'm sure, will glaze over at this point, and this is actually the point behind the talk. You oughtn't to glaze over. The experts they've gone on to discount sort of the things that go wrong for you based on the fact that the data from the clinical trials here is seemingly not statistically significant. Let's have a look at what the article also goes on to say. Now, we can all agree with the particular statement made here, but what you oughtn't to have agreed with is what the article in the BMJ concluded. And you can read the conclusion there yourself. 100,000 people read the BMJ from all over medicine: heart medicine, respiratory medicine, gut medicine, orthopedic medicine, whatever kind of medicine you care to think of. It's read by the FDA and the MHRA. And no one said, hey, wait a minute here. They didn't say the kind of thing that any 12-year-old school child could have told them, that, well, there is an increased risk here. Let me move on from this a little bit to try and deepen the issue for you. I'll give you a feel for how big an issue I think this is. Here is the data from the suicidal acts happening in the clinical trials of these three drugs here. These are the main three drugs used to treat people who are depressed here in the UK and in the US, or they were until recently. There's where the suicidal acts happened in these trials. You see the placebo suicidal act over there. Oops, I've gone the wrong way. I've pressed the wrong button and given away the plot. You see this act here. In the Prozac trials, that didn't happen. No one went on to suicidal act in the Prozac trials who've been taking placebo. But it's extremely important that the company, in actual fact, when they were handling the data, did this. They had moved a person from this arm of the trial up here, down here, and said this was a person who committed suicide on placebo. It was extremely important that they did this because this helped conceal the risk. All of the companies producing each of these three drugs did just the same thing, and the data went to the FDA and the MHRA here, and the FDA and the MHRA said nothing. They said, fine. Even though the FDA rules say that this is illegal. Okay, the FDA still say fine. 2003, the fuss about children becoming suicidal in this group of drugs blows up, and the MHRA asks the pharmaceutical companies for their data, and they say, we've just become aware that you've been swapping acts around the place. You've moved acts from up here down here. We don't want you to do that again. That was naughty. So GSK gave them their data and didn't do that. Instead, GSK did this, and this is a person who has been on the placebo arm of the trial, and after the trial is over, the person then goes on to be treated with Prozac, and on Prozac commits suicide, and this has become a placebo suicide. But even more, what's happened is it's been moved from the bottom up, okay? Acts have also been moved from here over, okay? Even when you do all of this, even when you move all of the balls around the place the way I've just moved the balls there, there is still an increase in risk in every single article that's been published. There's an increase in risk on the active drug than on the placebo. There has been an increase in risk for 15 years, and the FDA and the MHRA have done absolutely nothing at all. Look at this. This is a clinical trial whose main author is Dr. Stuart Montgomery, who in around this time was the lead expert for psychiatry on the MHRA. When the data from all these drugs goes through the MHRA, the mental health experts, Dr. Montgomery, was. Here's a trial on Prozac in people who've got what's called borderline personality disorder. The trial reported 6 years later or thereabouts. The trial failed to report this, which was that in the group of patients in the trial who were taking the placebo, that group had done an awful lot better than the group taking Prozac. Prozac was just much worse than not being treated with an active drug at all in this group of patients. So, Prozac didn't get put in any further trials in this particular group of patients, but GSK went back to Dr. Montgomery and got him to run a trial of paroxetine in the same group of patients. It could even have been just the same group of patients for all we know. But here's the outcome data from that, and these data didn't get reported at all, anywhere. So what do GSK do next? Well, they don't go back to Dr. Montgomery. This particular clinical trial was halted early. They don't go back to Dr. Montgomery, but they do decide to run a further trial in just the same group of patients. Now, we've had 2 trials with 2 drugs of this group where in both instances the drug turns out to be much worse than the placebo. Why would the company go back and run a further trial in just the same kind of patients? And here's the trial. Well, the answer, again, a point to make is that the data that you can find in the article here, if you were to go and read the article, is completely different to the data that GSK are going to report to you on the next slide that I'm going to show you. And it's completely different again to the data you would get to see if you were to actually see the raw data from this trial. Okay? That said, oh, well, actually, the data isn't on the next slide. It'll be on the one afterwards. This is from GSK. This is the data taken straight from them, 2006. Look at the bottom line. If you're able to look at the 2 bottom lines, the one from GSK, which is just here, and then the one from me, which is just here. What this actually shows you is that GSK, in their controlled trials, report that paroxetine is much more likely to make you suicidal. This is not children, this is adults. These trials go all the way back to the 1980s. Much more likely to make you suicidal than placebo. Much more likely. But if you add in the 2 previous trials that I've just shown you, the one done by Dr. Montgomery and then the one done afterwards, what happens is you get this 3rd line here, which completely changes the data. Okay, there's just the same number of people going on to become suicidal here as there is here, but if you add those data into the overall data, you completely change the overall picture. So it appears that the drug is more likely actually to it appears that the drug's more likely to actually prevent you going on to commit suicide. It was as clear as the nose on anyone's face for anyone who thought about the issues that this group of patients, this kind of patient group, would produce just this kind of result, which could be used for just this kind of purpose. I'm going to put it to you that this is the reason why these trials were probably run. But what I want to put you to now, I hope you're suitably shocked. I've left out a few more of the tricks that the pharmaceutical companies get up to. What I want to put to you is this, though. This is actually much more important than the thing you've just heard. What you've just heard is the kind of thing that will be picked up by the media who'll race out and say, we have a story that people can understand here. What I want you to understand, however, is that the key thing the companies actually depend on is not hiding the bodies the way I've just shown you. They actually depend on the fact that when they run trials of Prozac, and the suicidal acts look like this over here and like this on placebo, that 100,000 readers of the BMJ from all areas of medicine and the MHRA and the FDA will conclude that there is no increase in risk at all. Will conclude that these didn't happen. Will conclude that the scientific evidence is at odds with your personal experience when things go wrong on the drugs. When in actual fact, the things that happened to Claire, that happened to Millie, and that happened to all the people who went to the FDA and said there is a problem was totally consistent with the scientific evidence. But the companies can depend on doctors and the MHRA and the FDA not to see the problem. Let me skip that. Helps by the fact that all of these articles are, of course, also ghost-written. As you see over on the right there, these are 2 clinical trials which have been run by Pfizer for PTSD. And you see, if you're able to read the slide, that the articles have been completed, and they know which journals these articles are, will actually go to. They're going to go to they're actually going to go to the best journals in the field. And over on the left, you'll see author TBD, author to be determined. They will decide in the UK if they need the professor of medicine in Oxford or Cambridge or wherever, and in the US, Harvard or Yale or wherever. Here's the FDA. Recently, they've had a complete change of heart. They're now saying we need to ensure that all the companies bringing any drug to the market do trials to look at the risk of suicide. Of course, if you don't do the right trial, then you aren't going to find the risk. I mean, you may find an increased risk, but if you don't put a sufficiently large number of patients into the trial, the risk will not be statistically significant and therefore won't exist. But anyway, FDA have actually decided this because in the trials of the antidepressants done, obviously for people who are depressed, but also in people who are just anxious and who aren't at risk of suicide, there appears to be an increased risk. In people who use these drugs to lose weight, in those trials, there appears to be an increased risk. In people who use the drugs to help them stop smoking, who aren't depressed, there's an increased risk. In the anticonvulsants used for people who are bipolar, there's an increased risk. In the anticonvulsants used in people who have no nervous disorders, who are just on anticonvulsants to stop their convulsions, there's an increased risk of suicide. In the antipsychotics used for schizophrenia, where there was almost no suicides before the antipsychotics were introduced, there's a hugely increased risk. In the same group of drugs used for people who are bipolar, there's an increased risk. This is the drug that's been in the news just in the last week or so, again being used for a group of people who haven't got nervous problems to begin with. And all of the other drugs you see there, including a drug which I'm going to tell you more about, which is used to help people stop smoking. But before I tell you about that, let me just quickly show you the data. Awfully quickly, this is just the data on the antipsychotics being used for people who've got schizophrenia. If you compare the new drugs with people in the same clinical trials taking placebo, here's the increase in risk. It's a 3- to 4-fold increase in risk on the antipsychotic. If you look at these drugs being used for bipolar disorder compared to placebo, and these are the drugs that are used most frequently for people who are bipolar, here is the increased risk. Again, it's a 2.2-fold increase in risk. And I said I was going to tell you more about this drug. This is data from the MHRA just in the last few weeks. There are the fatal adverse events on this drug just in the UK that have been reported to the MHRA. The psychiatric ones, of course, are people who've gone on to commit suicide. In the general and nervous system areas, there are also people who have probably gone on to commit suicide. So actually the signal to the MHRA is an awful lot clearer than you see there. It's an even clearer signal to the MHRA than was for any of the SSRIs. What have the MHRA done? They've done nothing. Why? Because what happens to you on these drugs is just a case report. If you depend on your doctor to help you out in all this, well, have a quick look at this. These are the clinical trials that went to the FDA of the antidepressants used to treat people who are anxious. And this is quite a good journal. This is a high-powered group. And they report at the end of the article, as you see here, that in actual fact, an odd finding of this was we found that people who are anxious seem to be at an increased risk of going on to commit suicide than we had thought. What are the data that led to this conclusion? Well, here are the data. The data all happen in people on the drug, none happen on the placebo, but this becomes data that points to a risk from the condition we're treating not from the drug that we give you to treat the condition. So that's the response you're likely to get from your doctor, which of course leads to the question of who needs doctors. And when doctors don't even hold a meeting like this, when it's someone like Millie that has to hold it, we can ask the question. People who run the health services, though, are asking just this kind of question for a completely different reason, which is nurses are cheaper than doctors, and they're going to adhere to the protocols which say there are no risks from these drugs, and you should use the latest drugs rather than the older drugs, much more reliably than you'll get from your doctor. Which leads me to this joke, the only light bit in the talk, which was that when the fuss blew up about the antidepressants causing people to commit suicide, the response from the American Psychiatric Association was, we're awfully concerned about the idea about putting black boxes on these drugs. They said that antidepressants save lives. Very rarely will you see a suicide note in the course of a talk. Well, here's a suicide note from a profession, probably the only time you'll ever see it. What the American Psychiatric Association ought to have written, and would be this, and this is the kind of thing that I would like to believe, but of course I don't have a great deal of evidence for it, because the Royal College of Psychiatrists don't hold meetings to try and save lives. No area of medicine does. The humor here is black, it's not straight humor, so you're actually forgiven for the fact that you didn't laugh. I'm going to end with one or two quotes from Mary Ellen Winter, who, just like Claire and Millie, went to the FDA. Now, I'm not going to read all of this out to you. I'm sure at least the female half of the audience will be able to cope with me talking and reading this at the same time, even if the male half can't. Do two things at one time. But okay, what she's there saying, and she only has a 3-minute slot to frame the issues. And she says, as all of you would do, that, we grew up in a world where we thought that the FDA and the MHRA and medicine were on our side, and that the drugs we get to use were going to be better this year than they were the year before. But things have changed. Because her daughter Beth had been put on actually Seroxat and had gone on to commit suicide a short while later, she had begun to look at the issues an awful lot more closely and had changed her mind. And this is the world that she now sees, and this is how she put it to the FDA. The FDA and the MHRA here, and medicine generally in the UK and the US, has allowed our daughter to become the victim of a highly commercial enterprise that selectively releases clinical data to maximize sales efforts and seek only to gain corporate profits. But at least as striking was this report to the FDA from Millie Dowling about her 12-year-old daughter. Now, what you need to appreciate when you're reading this, the head person in FDA who is there saying, these are awful things that we're hearing, but the data says there is no problem, is a man called Tom Loughran. Loughran is up at the table. Millie is on the floor, and this is what she says to Tom Loughran, which is, our daughter, who is only 12, who was anxious about going to school, was put on Zoloft, and 4 days later goes on to commit suicide. She was a happy, loving little girl in a very, 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 very secure home. Just as secure as your home is, Dr. Loughran, because you and your family who live across the road from us were at Candace's funeral. This should not have been allowed to happen. We were given absolutely no warnings at all. The issue about did she go on the drugs at all or not should have been our choice to make, not yours. To continue to blame the victim rather than the drug is wrong. To make the kind of statements that you've been making about children who are depressed is wrong. The world we're in is a world where doctors used to practice medicine. Medicine means caring for your patients. Whether you care for your patients or whether you do it because you're professional, what happens when things go wrong for your patients is you stand up for them, even though the pharmaceutical companies and maybe the NHS and maybe what appears to be the science is on the opposite side. That's what it means to care. That's what it means to be a professional. In contrast, there are doctors who work in factories. Factories that produce chemicals that kill the workers working in the factories. And the role of that kind of doctor is to ensure that the employee that looks like they may be about to get ill gets retired or loses their job before it becomes clear that they have an illness that's been caused by the product being produced by the factory. That's the role of that kind of doctor. If we're to differentiate the two, we would say they both practice medicine of a sort. They both practice doctoring of a sort. One practices medicine, the other doesn't. And the difference between the two is caring. Medicine, when I say care, I don't mean it should be wishy-washy. It has to be evidence-based. But the current situation is we track the fate of parcels put in the post 100 times more accurately than we track the harms that we do to people when we put them on drugs, if harms are done to them. We need to actually decide if the key evidence in medicine is trials about do, say, drugs like the statins or the antidepressants work, or should it be about what are the injuries that these drugs cause? I would argue, or I would put to you, that actually medicine should be evidence-based, but at the moment isn't evidence-based. Factory doctoring is evidence-based. Medicine is almost dead. That leads me to the last slide, which is also a joke. It's the only possible slide to end on, given the quote you have here, which is that. Thank you.
Hi, so I've got a question for David Healy. I know the data that you've put up there is all related to SSRIs linked with suicide and depression. But I know you've also done a lot of research on SSRIs linked with aggression and violence. Have you got any data that you can, any sort of statistics that you can show us for that? I mean,
yes, there is clear data on this. At just the same rate as the drugs appear to produce an increased risk of suicide, they also produce an increased risk of people going on to be violent. But I don't have the data here with me. But yes, there is just as clear data.
And I know obviously you said that there was the other drugs, like the one for asthma, for example, that also reacted badly with the antidepressants. Is that the same for violence as well? I mean,
I don't know. That's an extremely good question, but I just don't know. And the reason that we don't know is that the pharmaceutical companies have all this data. They pick out the bits that suit them. They go on actually to market this to us. How they market it is they only have to market it to people like me. They don't have to market it to all the rest of you. They listen to people like me and say, we're influenced by the evidence. So what we get to see is the clinical trials, which have all been ghost-written, where the pharmaceutical companies know that they can perhaps put in a bit of data there, which, you know, a 12-year-old would be able to say, well, look, there is an increased risk here. And how the SSRI story unfolded was that how sort of things actually came to light in the end was journalists here in the UK who had no medical training at all looked at the data that profs of medicine, profs of psychiatry looked at and the MHRA looked at and said there is no risk, and the journalist said there is a risk. Anyone who's lay here in the audience who thinks this isn't your role, I mean, it's just not your role to take issue with the science, you need to think again. It is your role. If it looks to you like the data points to an increase in risk, there's a good chance there's an increase in risk, and that what has happened is that a pharmaceutical company has run a trial of a particular size on the advice of their lawyers that it oughtn't to be a bigger size than this, or the increase in risk will become statistically significant. Provided it's not statistically significant, we can depend on every single reader of the BMJ, New England Journal of Medicine, to say there is no risk. The deaths didn't happen. Vioxx did exactly the same thing. Merck reported in JAMA a trial where there were 5 heart attack deaths on the active drug versus 1 on the placebo, or the drug that was actually being compared with. That's in JAMA. There's a huge increase in risk. Merck reported it in the article that was ghostwritten, that there isn't any increase in risk at all here. Now, they'd hidden 3 extra heart attacks, and this is the kind of thing you hear in the media, and the media love. 3 extra heart attacks have been hidden, which would have made the data statistically significant. But it's not the 3 heart attacks you need, to actually worry about. It's the 5 heart attacks they're able to also make disappear, even though they're actually there in the article.
There were a few more questions. Yes, thank you.
Hello. My name is Val Baker. I'm a service user, and I was thinking about what you were saying about people committing suicide shortly after they've started courses of antidepressants. Now, I'd always been told that they actually took a while to take effect. I mean, I've taken SSRIs, 3 different kinds. I've taken the old tricyclics as well, and they can take quite a while to start to take effect. Can you actually say then that when people are committing suicide shortly after commencing antidepressants, that it is down to the drug or down to the condition? The other thing is, I wondered if the chemical makeup of some of the drugs had actually been changed, or whether they were being produced by different drug companies, because I actually take Prozac now and I find it less stimulating, if you like, than it used to be. I don't get as many bouts of shaking, and it doesn't make me as manic, if you like.
Can I just say something before I pass it on to David? It is very important that people realise that when drugs first come out, they might be called Prozac, but then they'll become something like Sarafem, or Dianet will become Claret. It's very important to find out what drug you're actually taking, because you might find you had a reaction to one. I believe that Sylvia Plath had a reaction to an antidepressant in America and was given the same one here under a different name. And I'd be very interested to see the papers that are now in the British Library to see what actually happened to her. But I think you should be aware of that. And I think David has made it clear from the slides that when the drug companies say it takes time for the drug to work, and you might feel suicidal or something because the drug, it takes time to work. It's the same as when they say about Roaccutane, that there's no causal link. There will always be these platitudes to tell you that it's not the drug, it's something to do with you. I don't know if David wants to add.
No, Minnie, that's fine.
Thank you.
Okay. Yes, at the back, yep.
Yep. Well, first of all, can I say a great big thank you to Professor Healy and Millie, because for me it's been like a lifeline, just knowing there are people out there fighting back. After my son died, after taking a 3rd tablet.
Who was, somebody here might remember her name, my mind's gone blank, but she She got together a whole lot of people. They had a huge petition. They got the FDA to listen to how many families, David? 100 or more? Families. They were given 2 minutes or 3 minutes to speak about the death of their child or their relative. Apparently the FDA was staggered, and they changed all the labeling. They suddenly realized this was actually happening, and they had to listen. So that was happening in America. And I was in the year 2000, I had a Millennium Award, which gave me a chance to study suicide prevention. I went to America. I was at a suicide conference. They have suicide conferences there, but they are funded by pharmaceutical industry, so they tend to be people holding hands and saying how sorry they are to each other, but they won't have David. I asked them to have David over there to discuss the effects of the drugs. And you even kindly spoke to somebody for me in America, in the suicide, I think the American Foundation for Suicide Prevention. And I remember in the conference, they said, one voice can be heard. And it is true. If a mother stands up and speaks, whether it's to the Women's Institute, for example, you could try that. Go and try to speak to groups. Tell people, like Claire is doing, you will make changes. It's like the butterfly effect.
Okay.
I've got a butterfly, haven't I, as my emblem. Let's all try and use the butterfly effect. Thank you.
I will. Thank you.
Thanks, Millie. There was a lady here on the corner, yes, and then
Oh, yes, thank you. I wanted to bring to the attention of the panel that fluoroquinolones antibiotics also have a very high incidence of neuropsychiatric side effects. And the symptoms sometimes can be also lead to suicide ideation, in which case, if a close member of the family is reacting and having very serious suicide ideation or psychotic episodes, would it be wise to perhaps abstain from taking antidepressants or psychotropic drugs?
So if I can get that clear, if somebody's on a fluoroquinolone, which is given for, it could be Cipro, which was given to my sister in America for a urine infection. I think it's given for anthrax as well, rather a strong drug. Then you do get these psychiatric side effects. There is a forum on the internet run by a lady called Beth in America. I'm going to ask David to answer that, because what you're saying is if somebody's having the adverse reaction to one drug of depression, is it wise to then give them an antidepressant? I don't know if you can answer that.
One of the interesting things about how all of this actually plays has been when the evidence comes through that there could be an increased risk from the drugs. The response from the FDA and the MHRA here, but even more so from the MHRA here, is to maybe be cautious about these drugs if you're depressed and suicidal to begin with. The issue about these drugs isn't that they make people who are depressed and suicidal worse. The issue is they make people who have nothing wrong with them at all. 12-year-old girls, people who may be on the drugs to lose weight or whatever, they make them depressed and suicidal. So how to handle that, how to treat that kind of depression is a bit less clear. It would seem intuitively to be the case that the usual response of give an antidepressant can't be the right one.
I just wanted to say quickly that my own research shows that it causes dysfunction in the GABA transmitters, and also it messes up quite a lot of the neurotransmitters. So it doesn't make sense to then go on taking psychotropic drugs when we don't know what the effects, the long-term effects of these drugs have on neurotransmitters.
Heather wanted to make a quick comment. Is it in response to that? Can you have a microphone, Heather?
Fluoroquinolones are known, as you said, to act on GABA receptors, and they displace benzodiazepines from GABA receptors. So that if, certainly, I don't know about antidepressants because they're not acting on the same receptors, but if you give somebody on a benzodiazepine, a fluoroquinolone, you can cause fits and insomnia and severe anxiety. And even on their own, fluoroquinolones, because of their, they block GABA receptors, they can cause fits. So, and of course, antidepressants also cause fits. So, I mean, it's a complicated story, but they are antibiotics to avoid if you can.
Can I just say, before Pam, I think, wants to ask a question, that I should mention the Seroxat user group, SUG. I think it's seroxatusergroup.org.uk, but there is a link on my website, and obviously you can look it up on Google. And I don't know if Janice is here today, but there may be somebody, is Janice here? There may be somebody from SUG. They are trying their best, although it was set up for the Seroxat problem, they are dealing with all the antidepressants, so it's probably worth getting in touch with them if you want to find a group that's trying to do something about the SSRIs. Thank you.
There was a lady, was it the lady in the red top, sorry to point, for, or someone in this area before Pam? Yes. And then, sorry.
I'm here today because my partner actually committed suicide. He, I feel, was misdiagnosed with mental illness, and he was on a cocktail of medication. And my concern is, if the statistical data shows that one medication like Prozac can give suicidal ideation, then what about a cocktail of olanzapine, lorazepam and Prozac combined to a person that's been told by a psychiatrist that he probably doesn't need to be on it, and then given a very short withdrawal period and some diazepam to take away with him? My concern is, what does actually that sort of chemistry do to a person who is well? You know, and I think that sort of goes back to Claire as well, because I think I never knew that a cocktail of anaesthetic drugs was being used. I've got a friend going in next week now for an anaesthetic for an ARP, and I am really concerned. I don't know what to do or say, you know, as a result of today, but I am very concerned. And I think it's this pharmacology that, you know, that nobody seems to be doing the trial. I don't know, are people doing trials on the combination of drugs that are being used? You know, because these are obviously very strong medications used in conjunction.
There are very few
together.
trials conducted on multiple drugs, and yet very many people in the psychiatric system are prescribed multiple drugs.
Yeah.
So therefore we really don't know what their effects are.
And I think another concern of mine is for the elderly, because, you know, I've also got an elderly father who's has been prescribed citalopram for depression when he isn't really depressed. I mean, he's got a reactive depression rather than a clinical depression.
Can I just say something about this polypharmacy? I'd like to ask David myself, is one of the reasons for polypharmacy giving more than one antidepressant, more than one antipsychotic, to sort of spread the risk for legal reasons or litigation reasons?
Ooh, Millie, I think doctors in good faith probably are told that the clinical trial has shown the drug works. Now, in the case of the antidepressants, what you've got is 5 people out of 10 appear to show a response to the drug on a rating scale. 4 people out of 10 in the same trials show the same response on a rating scale. So, in actual fact, you know, the evidence points to the fact that, well, the drugs may do something, but actually you oughtn't to be using them first, because 80% of the people who would respond to the drugs would respond even if they weren't given the drug. But doctors, again, just the way they misread the figures that I put up here, get told that the figures from the clinical trial means the drug works. So if you don't respond to the first drug we put you on, it seems a good idea to have you on 3 or 4 drugs that all have been shown to work, when in actual fact we're actually producing a situation I think you described quite well, which is, well, actually you've been put on a drug where the best thing we can say is that this drug, it's just not true that this drug does nothing. But to put you on 4 different drugs where all we really know is that it's just not right to say the drug does nothing is clearly a recipe for things going wrong.
Pam's been waiting for a while.
I just wanted to say that we have, to go back to the antibiotic story, that we've noted for several years now that both with benzodiazepines and antidepressants, people who can be doing really well in their withdrawal or people who have recently come off, when they take an antidepressant, get a flare-up of withdrawal symptoms, often becoming very agitated and low. This also happens when they have a flu injection. And with the antibiotics, we often suggest that they take probiotics, which seems to help. With the flu injection, there's no real remedy except just what that seems to only last a few weeks, and then they seem to settle down again. But it is an observation that we've been making, and it applies to all antibiotics as far as I can see.
Right, thank you, Pam. That's Pam from CETA.